Hi, my name's Natalie Como. I'm an internal medicine pediatrics physician at University of Utah, where I work as a hospitalist. I also work half-time at the community hospital of Anaconda, which is a critical access hospital in Montana. Myself, Casey Gradick, Dave Sandweiss, and Clinton Sheffield are working on curriculum development for an internal medicine pediatrics rural training track. As a little bit of background, there's a need for primary care providers in the rural Mountain West. There are currently 30 family medicine rural training tracks nationwide, but there's 0 in med-peds. We believe that internal medicine pediatrics trained physicians are well suited to practice rurally. This is a residency that's 4 years long, and graduates leave board certified in both internal medicine and pediatrics, allowing them to care for the full spectrum of ages. Our objective is to develop a med-peds rural training track. So the goal of that training track would be to recruit, train, and graduate med-peds primary care physicians who are well prepared and committed to practice in rural and underserved areas. We'll have a particular emphasis on management of opioid use disorder, mental health, and telehealth. Right now, we have a well-respected med-peds residency program at University of Utah, but for this, we're gonna develop a whole specific rural curriculum. For curriculum creation, we'll need to both think about a rotation schedule and logistics. So when and where our residents going to rotate at different sites. We'll also create some formal learning objectives. Right now, we're working to establish partnerships with rural clinical sites in the University of Utah catchment area. So on the right here, the red is Salt Lake City, where University of Utah is located. Just to the west of that is Mountain West Hospital in Tooele, Utah. To the east is Uinta Basin Medical Center and Ashley Regional Hospital near Vernal, Utah. In Wyoming, we have Evanston Regional Hospital, as well as some VA sites. Up in Montana is Community Hospital of Anaconda, where I work. Down in Southeast Utah is the Blue Mountain Hospital in Blanding, Utah. And then Northern Arizona on the Navajo Reservation is the Chinle Comprehensive Care Center. Also, as part of this, we would like to connect with other rurally focused programs that already exist at our institution in the health sciences. There's a little bit of literature on rural curricular competencies. Most of this is from family med programs here in the US or some international programs. But we believe that there are some practical skills and psychological skills that will be important for training rural physicians. Examples of practical skills would be performing your own procedures and things like that. Psychological skills would be ways we can prepare our residents to find satisfaction in rural practice. So the first competency would be adaptability. This is the ability to shape one's skill set to the needs of the community. So as part of this, we plan to create formal modules regarding rural health disparities and challenges that rural hospitals face. We also plan for some medication-assisted treatment or opioid use disorder training for residents. Second is improvisation. This is how to use the resources and skills available that you have in that moment, realizing that as a rural physician, you might not have everything at your fingertips like you might in an urban area or an academic center. Third is lifelong learning. So this is learning what resources are available in high yield to maintain up-to-date knowledge as a rural physician. Obviously, you have to keep your knowledge up and keep your practical skills up. So we want to teach residents what are some of the ways to do this. Next is collaboration. And first, this kind of involves how do you ask for help when you need it? This could be over telehealth. And so we plan to have a formal telehealth curriculum. We also want our residents to function well in a multidisciplinary team. So as part of these rural rotations, we'll have time set aside that residents can work with and learn from non-physician members of the care team. And then finally, we have resilience. So this is the ability to continue to re-energize your practice and maintain enthusiasm in the face of potential professional or social isolation. So we plan to create a formal wellness curriculum to discuss some of these topics and more psychological challenges of being a rural clinician. How are we going to evaluate the program and how are we going to collect data? The first thing that we plan to do is a rural clinician needs assessment. So this will be reaching out to some rural clinicians in our area, asking them what are some of the things that you wish you knew or wish you finished residency with to become a successful rural physician. Next, we'll get resident feedback. So we plan to have a graduation time survey about the curriculum and how well they feel prepared in that moment. And then we'll also get their feedback after they've been in practice a couple of years to see if in reality they had the skills that they felt like they needed. Finally, we'll be tracking retention in rural practice, since our overall goal is to create primary care physicians that stay in rural practice. We'll be tracking that and getting numbers on that as well. So with that, thank you for listening. We all look forward to connecting and learning from others that are involved in this rural education space.